Hey everyone, welcome to EMCCM conference. My name is James. I'm one of the fourth year EMIMs for those of you who haven't met me. Thank you to Dr. Zacone, D'Souza, and Kim for their contribution to the presentation. I'm going to start you off with a setting. I know it's in the morning right now, but put yourself in the situation. You're in CCT. It's 1 o'clock in the morning. There have been a bunch of codes overhead that night, and then you hear a code 66 called to the R building. Around 15 to 20 minutes later, you hear a ruckus in the recess bay. So for the pre-ED history, the chief complaint, written directly as it was written in the chart, brought in from CPEP for a syncopal episode, shortness of breath, tachycardia, and hypotension, escorted by a medical team and aide, none of which were there. The vitals that was noted in CPEP was 119/61 for blood pressure, heart rate of 82, and a respiratory rate of 60. So for your initial assessment, airway, no secretion. She was able to speak clearly and still able to respond to you. Breathing, clear breath sounds bilaterally, very tachypnic. Circulation-wise, palpable pulses, mildly diaphoretic, and cool extremities. For disability, she seemed like she was confused, but she was still able to follow all directions. It was difficult to tell whether she was had the compensated psychosis because she's coming from the R building versus whether she was actually confused because we didn't really know her baseline. Otherwise, no facial droop, moving all of her extremities. Initial vitals, afebrile 98.3, heart rate of 161 initially on the triage vital, but when you put her on the monitor, you see that the heart rate's been fluctuating within the 130s to 140s. Triaged at 93/63 blood pressure with a MAP of 73, but when you're recycling the blood pressure, you do see it's in the 100s to 110s. Tachypnic to the 30s, setting 92% on 15 liters non-rebreather. Glucose was 182. So for your preliminary problem list, we have signs of shock with a patient who seems like she's confused, diaphoretic with cool extremities, with a below normal blood pressure. Tachypnea, hypoxemia, syncope, and altered mental status. So for your initial interventions, the team put her on a cardiac monitor, started high flow nasal cannula at max rate at 60 liters per minute and 100% FiO2. Gave her a 1 liter normal saline bolus. Gave her 2 milligrams of IV push midazolam because she was seemed like she was ripping off her non-rebreather mask pretty frequently. So and she was a little bit disoriented. So the team gave her 2 milligrams of midaz. An ECG was ordered and a POCUS was planned for the heart and the lungs. So for the rest of your physical exam, when you got around to it, obese, anxious, confused, again, taking off her mask. Oropharynx was clear, no congestion noted. The rest of the cardiovascular exam, very limited assessment of the JVD because of her habitus, and bilateral mild pitting edema. Again, tachypnic and clear breath sounds bilaterally. Abdominal exam was non-remarkable. Neuro exam, again, moving all extremities and following commands. On your reassessment, the systolic blood pressure seems to be fluctuating between the 90s and 140 systolic, remains tachycardic to the 140s and 150s, and now on the high flow at max settings, she's setting high 90s on the high flow. Remains tachypnic. I'm going to give you guys a moment to take a look at this EKG. You do note, just to kind of push things forward, sinus tachycardia. There is right axis deviation. There's also ST elevations, an AVR, V1 and V2, and a QR and V1. I'm going to move on. And this is her initial echo. I'll give you guys a chance to look at it. Sorry, it's a little flipped for those of you who are like, what am I looking at? This is the right ventricle. This is the left ventricle, aortic outflow tract, and left atrium. Everything else should be in accordance with which everyone is familiar with afterwards. This is the parasternal short. the apical 4. Again, right ventricle, right atrium, left ventricle, left atrium. This is the TAPSE. We're going to go over this later if you're not familiar with what this is, but here it is. And lastly, this is the left femoral common femoral vein. We're not showing that it's non-compressible here, but you can definitely see something in there, and it was definitely non-compressible. And do note that a lung POCUS was done. I just didn't include it because it was definitely negative, A-line predominant. So for the rest of your HPI, you're unable to obtain a full history, but per the chart from what the initial provider note stated, 59-year-old female, history of schizophrenia and hypertension, presenting with status post syncope, altered tachy and hypoxemic, in CPEP, found on the bathroom on the floor, confused in stool. For the rest of the contributory history, really not that remarkable. She's not on any medications that would be pertinent, no blood thinners or anything like that. She's allergic to penicillin. So for further testing and consultations, you order a panel of labs, get imaging tests, including a CT head and a CT-PE, and call ICU. So for the results, a white count of 18. Otherwise, on the BNP, a bicarb of 12, BUN of 16 over a creatinine of 1.7, a pH of 7.28, and a lactate of 10, with a PCO2 of 34. For the LFTs, a transaminitis with AST of 219 and ALT of 119, a high sensitivity trope of 480, and a pro-BNP of 2700. Her chest X-ray, I'll give you a moment to take a look at it. And there's really nothing much remarkable about this chest X-ray. So for the rest of the ED course, she received another 2 liters of normal saline, separated over a course of 2 hours. The team did note worsening tachypnea and progressively persistent hypoxemia with an SpO2 of 70% on max hyphonasal cannula. And nearing the tail end of the 2 hours, her systolic blood pressure continued to drop. It stopped fluctuating between like the 90s and 140s and was persistently in the 80s. So the decision was made alongside the MICU team to intubate and give thrombolytics. So she was started on a peripheral levofed drip from 5 to 15 mics per minute. She was given 50 milligrams of IV push alteplase prior to the intubation. RSI with a time of 20 and ROC of 70 was done, and intubated on the vent settings below, tidal volume of 500, PEEP of 5, and an FiO2 of 100%. Post-intubation, soon after, started to have increasing hypoxia, bradycardia, and eventually PA arrest. ACLS protocol was initiated. She received a total of 3 cardiac epis during the code, received another 50 milligrams of IV push alteplase, soon after had ROSC and was transferred to MICU. So for the discussion today, I want to talk about high-risk submassive pulmonary embolism. We're going to have 4 major talking points today. Briefly, we're going to talk about the classification of PE. Secondly, we'll talk about the determination of RV dysfunction, specifically with echocardiography, management of acute RV failure in the setting of PE, and thrombolytics in high-risk submassive PE. So let's start with the classification of PE. So we're all used to seeing the 3 major tiers of PE classification. So I'll start with low risk. These are the patients that, whether you didn't even think you were going to find a PE and you ended up finding a PE, or they're super low risk, they're not spilling any tropes, they're not spilling a BNP, and their right heart is not dilated. You admit them to the floors or you even discharge them based on their risk factors. So we're going to put that on the side. They just get anticoagulation and whatnot. Then you have on the opposite end of the spectrum, you have massive versus high risk. And low risk, massive, high risk, all these terminologies are based on whether you're using the AHA classifications, which is low risk, submassive, and massive, versus the ESC, or the European classifications, which says low risk, intermediate, or high risk. And these patients are hemodynamically unstable. but based off of the AHA classifications, technically requires an SBP less than 90 for at least 15 minutes, or a systolic blood pressure from your baseline that's dropped more than 40 millimeters of mercury, again, lasting for more than 15 minutes, or if they're requiring pressor support. Essentially, they're looking for sustained hypotension. And in the middle of all of that, and for massive high-risk PE, I think everyone here is aware that lytics are indicated for that group of PE. Everything in between, from your patient that's looking great to a patient that's looking terrible, is classified technically as submassive PE. And the ESC guidelines does try to risk stratify a little bit based off of whether RV dilation and RV injury is present based off the cardiac biomarkers. But no further classification is done further than that. I do want to mention that RV dysfunction is associated with a significantly worse outcome than patients with just regular low-risk PE in that hemodynamically stable group. But it's important to say that there's a really broad range of what we talk about when we say RV dysfunction. So going into my favorite topic, determination of RV dysfunction with echocardiography. So I want to start off with something that everyone can do, and that's 2D visualization. Everyone knows how to put the probe on the chest and try to get the image and see what you kind of see and try to interpret what you can see without using any of the fancy modalities. So let's start with the size. So the RV size compared to the LV normally is around 2/3 of the LV. So that's demonstrated on the picture on the left. Severely dilated is greater than 1:1, and what we call apex forming. The apex is kind of cut off on this picture, but you can imagine if you were to extrapolate out, the RV would kind of make the apex of the heart. So you definitely see that the RV is more than one, greater in size than the LV, and again, the apex of the heart would be formed by the RV. Anything in the middle would be mildly dilated, moderately dilated. I don't think that's really that important in the emergency department setting. Another thing that's important to look at while you're looking at size would be the function of the RV. So if you look at this RV free wall, is that free wall coming in and actually decreasing the area and size of the RV? Is that tricuspid annulus, the base of the heart, is it moving towards the apex? And can you replicate these signs on multiple views? So it's really easy sometimes to take a look on echo and get one view and say, oh, this person has RV dilation, when you're just off axis, or you're assuming things based on a 2D picture of a 3D thing. So you do have to replicate some of these things on multiple views. So if you have a heart that looks like this, on your parasternal long, you should also see a large RV, and on your parasternal short should also see a large RV as well. The next 2D visualization modality that I want to talk about is McConnell sign. Many of you, I'm sure, have heard of this, and our patient demonstrated it on her echo. I'll give you a chance to take a look at it. The McConnell sign is defined as RV basal and free wall hypokinesis with the spared apex. Some people say if you were to put a person on here and kind of jump up and down, you would see someone jumping on a trampoline while everything is holding still. It's not that the apex of the RV is for some reason resistant to the pressure overload. It's actually that this area of the RV is connected to the shared septum, and as the LV contracts, it's being pulled along for the ride. The RV is actually doing nothing. It's just that this thing is just kind of going up and down here. All right. So that's McConnell sign. And lastly, I want to talk about, I think, the emergency department's favorite sign, the D sign. I want to introduce this term called ventricular interdependence because it's going to become important later. So again, our patient's echo. So this is the left ventricle and this is the right ventricle. The heart is encased in a pretty in a pericardium that doesn't allow for much expansion. So in the acute setting, when there is a large PE and there's things distal to the RV, there's not a lot of space for all the fluid to go. So what happens is as the pressure in the RV becomes bigger and bigger, the septum starts to bow into the left. And you can theoretically tell the difference between whether someone has a lot of pressure overload and a lot of volume overload by when the septum starts to bow within the cardiac cycle. So if the septum is bowing more during systole, then you can say the person is more pressure overloaded. And when the person's, or if the septum is bowing more during diastole, you can say the person's more volume overloaded. It's a little difficult to say in our patient, but to be honest, I think you see the D sign throughout the entire cardiac cycle. And you do also note that the LV is really underfilled. I would call this even like almost like 100% EF and a very underfilled left ventricle. Okay, so now moving on to a little bit more advanced modality on echo. We're using M mode, and everyone is familiar with M mode. If you've gone through your sonor rotation, everyone I think hears about the thing called EPSS and whatnot. So let's talk about TAPSE, tricuspid annular plane systolic excursion. So this is M mode applied to the lateral tricuspid annulus. It should technically be in the RV focused view. What the RV focused view is, you take your apical 4 and you move your probe a little bit medial to get this right ventricle to be in the middle of the screen. The representative picture here was doing a terrible job because the LV is in the middle of the screen. It really should be the RV. And you apply M mode and you get this picture here. So the tricuspid annulus is going to move up and down, and this line of interrogation is going to basically trace the amount of moving that this lateral tricuspid annulus is going to do. So on the x-axis is time, and on the y-axis is distance. And as the tricuspid annulus moves up and down, it creates this tracing. And what you want to get is the distance between the peak and the trough. And this will tell you the number of what the TAPSE is supposed to be. The reason why this matters is because the RV is predominantly made up of longitudinal fibers, which goes up and down. And it's a pretty decent marker of RV systolic function and is very replicatable. The normal TAPSE for everyone in the crowd, hopefully, should be around 20 to 30 millimeters, or 2 centimeters to 3 centimeters. So this person is exhibiting a normal TAPSE here, even with the poorly aligned M mode. By the American Society of Echocardiography guidelines, a TAPSE less than 16 millimeters suggests reduced function. And another reason why this is important is because it's a way to communicate with your ICU colleagues, your IR colleagues, and people that you're trying to tell that this person's RV dilation is not just dilation, the person's systolic function is actually impaired because of the PE. And this is our patient's TAPSE here. You do see the RV focused view with the M mode applied to the lateral tricuspid annulus, and you see that it's barely doing anything compared to the prior picture. Her TAPSE was 0.9 centimeters or 9 millimeters. All right, so there's other stuff that we could have gone over, like 60-60. If you guys want to talk about that, we can talk about it offline. But for time's sake, let's move on to the management of acute RV failure in PE. So we talked about the classification. We talked about how to determine RV dysfunction. So what do we do about this RV dysfunction would be why I'm going to this next topic. So in order to talk about RV failure in PE, we do have to focus a little bit on physiology. So the first thing we want to talk about is the right ventricle versus the left ventricle. And in terms of mass, the right ventricle has around a quarter of the mass and a third of the thickness of the LV. And the intrinsic contractile capability is around a fourth of the LV as well. We discussed fibers a little bit when we were talking about the TAPSE. The LV has 3 major fibers. It has the radial fibers, which contract inwards that you see on your parasternal short. It has the longitudinal fibers, just like in the RV, that goes up and down. And the LV also has some torsional fibers as well. But again, the RV is made up of predominantly longitudinal fibers, around 80%. And the perfusion of the RV happens normally during, this is really important, both systole and diastole. So when you're having RV failure and pressure overload, and your pulmonary artery systolic blood pressure is going above your coronary perfusion pressure, you're actually causing ischemia to the RV because it's not being perfused throughout the entire cardiac cycle, which the RV is used to. This is unlike the left side, which gets perfused during diastole. So for the RV contractile function, the shared septum of the RV is known as the lion of the RV. So there was an experiment done in dogs a long time ago. So they paced just the RV without activating the right heart, and they traced the amount of like flow in the pulmonary artery that they got. They ended up generating decent RV pressure and flow by pacing just the LV. Then they decided to pace just the RV without pacing the LV, and it led to almost no flow from the left ventricle. So they concluded that around 50 to 60% of the contractility was accomplished by the LV contraction itself. So let me bring back this concept of ventricular interdependence. When the RV starts to really enlarge and it starts to bow into that septum starts to bow into the LV, the septum ends up flattening and you get hypocontractility of that shared septum. So if the lion of the RV is hypocontractile, it'll markedly impair RV contractility. I'm going to introduce this other topic, which is super important and seems super complicated, but hopefully we'll try to simplify this a little bit. It's called pulmonary vascular compliance versus systemic vascular compliance, aka afterload. In the left-sided circulation, the aorta or the large vessels makes up around 80% of the compliance. On the right side, though, the small, tiny little vessel, the small pulmonary arterioles, the small capillaries make up more than half of the pulmonary vascular compliance. Meaning these small arteries are heavily responsible for pulmonary afterload and therefore pulmonary vascular resistance. And even at baseline, pulmonary vascular resistance is around 1/10 of the systemic vascular resistance. Why does this matter? So they've done this experiment. So where they've increased the amount of afterload on the left side, and you do see, so it's afterload on the x-axis and stroke volume on the y-axis. So for the left ventricle, as afterload goes up, you see that there's very minimal decrease in amount of stroke volume that the left ventricle is able to generate because of the thick-walled LV. But when you increase afterload acutely for the right ventricle, see how acutely the stroke volume starts to drop. So the conclusion is afterload is the primary determinant of RV function. That weak right heart is not capable of generating enough force to sustain a stroke volume in the setting of acutely elevated afterload. So, James, I thought the RV was preload dependent. What is all this talk about afterload? You're confusing me. What the heck? I thought all I had to do was just give fluid. Well, that's a very simplistic way of thinking about a very complex thing. If you have no problems with afterload whatsoever, and so for example, during an RV infarct, when all you have is a problem with the RV contractility, and the pulmonary arteries are free, there's nothing there, there's no issue with afterload, fine, you can be preload dependent. The RV sort of in that setting, the RV just sort of becomes like a conduit for blood flow. If any of you are familiar with the Fontan procedure, that's kind of what it's like. And the mean systemic filling pressure, or just preload, the pressure kind of, in the volume of the blood is what actually determines forward flow in that setting. However, in the setting of high afterload, when there's flattening of the septum and there's hypocontractility of the line of the RV's ability to eject that preload that you give it is very low. So let's kind of go through, and you enter into this death spiral. I'm sure everyone's gone through it since medical school, but let's kind of go through it together. So if your RV is not able to eject the preload out, so the cardiac output of the RV will fall. The amount of blood that is ejected from the RV is the amount of preload that the left ventricle is able to receive. So the left ventricle only receives what the right ventricle gives it. If the RV, because of decreased contractility, is unable to give the left ventricle any volume, then your left-sided cardiac output will inevitably drop. And that decreases your MAP. When the MAP decreases, your RV perfusion pressure decreases as well. So you're going to start having RV ischemia. Remember, recall back, the RV should be perfused throughout the cardiac cycle, but when that's not happening, it'll cause ischemia. When it causes ischemia, you're going to get further decrease of the RV contractility and a further decrease in the amount of blood that's able to go to the left side, and further drops your MAP. So you see how there's this cycle that's going on, and that's called obstructive shock. If you give more and more preload to this already strained RV, it's going to further distend the RV, further compress the LV, and essentially drown the right ventricle. So in optimizing preload, consider giving IV fluids in small aliquots, 250 cc's, 500 cc's, only if you see that the IVC is flat, which suggests that your right atrial pressure is low. This should not be the case in an RV facing massive amounts of afterload, like in our patient with a high risk of massive PE or patients with massive PE. So there is a consideration where you can consider slow controlled diuresis in these patients in order to in the attempt to try to offload the RV. I think diuresing a hypotensive or hemodynamically unstable patient is pretty scary. And this, again, should be driven by echo findings, and it should be done in a slow, controlled fashion. So my conclusion about this in the emergency setting is let the ICU do this. So how do you find? You convinced me, hopefully. I convinced you guys to reduce the RV afterload. So how do we do that? The most important thing in reducing RV afterload is going to be dealing with the thrombus in the PE. That's going to be a whole section in a little bit. So I'm going to discuss that in a bit, but I just want to emphasize that's the most important thing. In the meantime, what else can we do? So consider pulmonary vasodilators. You have a couple of options. Nitric oxide at around 10 to 80 parts per million can decrease your pulmonary vascular resistance by around 20%. A caveat to this, it may take a lot of time for the respiratory therapist to bring up that tank, and it's super expensive. I did ask the respiratory therapist if this is possible. They're like, I've never seen that done in the emergency department, but we do that in the ICU. As a quick, cheaper alternative, we can consider nitroglycerin 5 milligrams nebulized over 15 minutes. It'll decrease the pulmonary vascular resistance without an effect on the systemic vascular resistance, but only lasts around 20 to 30 minutes. It's a temporizing measure. So while you're attempting to improve the afterload, avoid worsening afterload. And how do we worsen afterload? Okay, so intubation and positive pressure ventilation is probably the predominant way that we do this. So I'm going to refer you to the figure on the left here. So pulmonary vascular resistance is on the y-axis, and the lung volume is on the x-axis. When your patient has a bunch of atelectasis, they're not really breathing, they're hypoventilating, you note that your pulmonary vascular resistance is high. But as you recruit all the alveoli and you achieve something called FRC, your pulmonary vascular resistance is at its lowest. But when you over-distend the alveoli, note how high your pulmonary vascular resistance goes. And now let's refer to the picture on the right. So remember that in the right-sided circulation, the small pulmonary arterioles and the capillaries make up more than 50 to 60% of the pulmonary vascular resistance. So let's look what happens when you over-distend some of these alveoli, like on this section of the graph here. So you're compressing, by over-distending the alveoli, you're compressing these small pulmonary capillaries and causing an elevation in your pulmonary vascular resistance. So when you intubate these patients or you put them on non-invasive ventilation, in addition to all of this, you're also going from negative pressure ventilation over to positive pressure ventilation. So during negative pressure ventilation, you take in a deep breath, you cause negative intrathoracic pressure, you get a little mini bolus of fluid from the IVC, and it makes it a lot easier for the RV to push the fluid out because there's negative pressure. But when you flip that into positive pressure ventilation, think about there's a lot of pressure in front of the RV already in the setting of PE, and now you're adding positive pressure on top of it. That's going to potentially flip them over into a bad place. So avoid worsening afterload. Additionally, how else can we reduce RV afterload? Deal with the hypoxemia. Target an SpO2 of greater than 95%. And high flow nasal cannula, because of the points mentioned prior, is probably better than non-invasive ventilation. Deal with the acidosis. So this is a topic that's way beyond the scope of this lecture. If you want to talk about it offline, everyone has their different opinions on bicarb and all these things, but let's talk about, I just want to introduce you to what acidosis can do to the pulmonary vascular resistance. So take a look at this graph here. Let's look at the normal oxygen tension at around 100. When your pH is normal, your pulmonary vascular resistance is at this level. As your pH drops, notice how high your pulmonary vascular resistance can get just with a drop in the pH. And now add to that decreased oxygen tension and look how far up your pulmonary vascular resistance can go. How So how do you reduce RV afterload? Again, deal with the hypercapnia. At around a PCO2 of 55 to 60, your pulmonary vascular resistance increases by 50%. Okay, James, but you said you can't use BiPAP, so what are we going to do? Well, yeah, but high flow nasal cannula isn't just for oxygenation. It can help to wash out that anatomical dead space, and it also helps improve alveolar ventilation in the attempt to avoid BiPAP. And lastly, support your RV contractility and defend your MAP. So option number one, and the most recommended option, is Levophed, norepinephrine. It's a beta-1 and alpha agonist. Helps improve the contractility of the RV, LV, and helps to defend the MAP. It does increase your pulmonary vascular resistance to a mild to moderate level, but there's a net positive effect due to the ability for you to raise your systemic blood pressure. Vasopressin is the next line. It's a pretty elegant way to choose one of your pressors. It works on the V1 receptors. There are no V1 receptors in the pulmonary vasculature, and it works solely on the systemic side. And again, helps to defend your MAP in order to sustain RV perfusion. And lastly, you can consider epinephrine. There's more non-selective beta agonism. It can possibly cause pulmonary vasodilation. The beta agonism, again, can help with RV contractility. And possibly, theoretically, there's no studies or anything like this, but can possibly defend against that Brady down common pathway PA arrest that these PE patients go to. So now that we've talked about the classification of PE, we've talked about how to determine the degree of RV dysfunction, and we've talked about acute RV failure in PE. Let's talk about the most important part of a high-risk PE, which is direct afterload reduction by thrombolytics. So the current evidence in submassive intermediate risk PE, there's a few studies out. They're all questionable in terms of their quality, but I do want to briefly discuss some of the more important ones that's out there today and that get referenced a lot. The Moppet study and the Wang study were the ones that were, I guess, establishing the dose of half-dose TPA. Quickly, the Moppet study, half-dose TPA with anticoagulation versus just anticoagulation in quote-unquote moderate PEs. It wasn't even submassive PEs, but moderate PEs. They established that half-dose TPA works and is safe for these moderate PEs. There was no bleeding in either group in the Moppet study. The Wang study used half-dose TPA versus full-dose TPA in massive PEs. They trended three things. They trended the echo findings, they trended the VQ scan for perfusion, and they trended the CT angio for PE for clot burden. And in their study, half-dose TPA was just as efficacious in massive PEs as full-dose TPA. The PATHO trial was a RCT done in 2014. They used full-dose TNK along with anticoagulation versus just anticoagulation for submassive PEs. The conclusion was that it statistically did improve mortality or hemodynamic decompensation, but there was a significant risk of increased risk of bleeding with the lytics. I put a little asterisk here because of the way that the trial worked. One, the submassive PEs that they incorporated in this group, the majority of these patients just had a little bit of a trope leak and didn't necessarily even have RV dilation. The way that they did their lytics and their anticoagulation was they bolused the heparin first and then gave full dose TNK and targeted a PTT at 2 to 2.5 times the upper limit of normal, which is a lot higher than what we normally choose in our institution and the normal colloquial way that we normally give TPA and anticoagulation nowadays. And lastly, the Chatterjee trial, the meta-analysis done in 2014, soon after the release of the PATHO trial, very similar conclusions to the PATHO trial. They did note a subgroup of the age of 65. Above the age of 65 was a significantly higher risk of bleeding, and below the age of 65, there was an equivalent risk of bleeding with the lytics versus anticoagulation. No trial has included a subgroup of higher risk submassive PE patients. No one's ever looked at that group. No trial with submassive PE done comparing full versus half dose. And no trial has ever been done comparing either half or quarter dose TPA with IR guided therapies. So in terms of giving thrombolytics, I think this might be one of the most important slides in this lecture. use your clinical judgment. Who is out of the submassive PE, out of that huge range of patients who get classified as a high risk as a submassive PE, who is the sick high risk submassive PE patient? So clinical signs of obstructive shock, without even if they're not meeting that massive PE criteria of this, it's actually pretty crazy. The HA guidelines the HA guidelines is back from 2011. There have been no new guidelines since then. It requires this systolic blood pressure less than 90 for a sustained period of time, at least 15 minutes. But if your patient is looking sick and they have signs of shock, they're altered, they're diaphoretic, they're cool to touch, and then I think those patients should be placed in a different category than most of the other submassives. I'm going to refer you to the shock index on the third point. The shock index is a heart rate over systolic blood pressure. And if that's above 1, your patient's heart rate is 140 with your systolic blood pressure of 100. It's actually been shown to be pretty sensitive in predicting adverse outcomes in PE. And echo findings, there's just RV dilation. Maybe your RV is just 1-to-1 for the LV, but your tricuspid annulus is moving really well, and the RV looks like it's functioning really well. That's really different from an RV that's showing McConnell sign. It's showing complete compression of the LV because the RV is so dilated, and when the TAPSE is like 9 millimeters, like our patient. And a high lactate. A lactate showing hypoperfusion. It's not just showing that, it's showing that your patient's endogenous catechol are going through the roof because of this PE that's in their pulmonary vasculature. This is from the guidelines from the AHA. Again, on the right side, massive PE. Yeah, there's no contraindications to fibrillanolysis. Okay, lyse them. Do look here in the middle, submassive PE with RV strain. Even back in 2011, 13 years ago, they did acknowledge that if there's any evidence of shock, hypotension, shock index above 1, moderate to severe RV strain, to consider alteplase. And that was a 2B recommendation at that time. At any point when you're considering to give thrombolytics, consider their bleeding risk. Maybe use the age 65 cutoff based on the Chatterjee meta-analysis. High bleeding risk contraindications, the common ones that we always use, prior ICH, brain aneurysm, ischemic stroke within 3 months, major surgery within the past 2 weeks. Look this up on NV-Calc, look this up on the AHA. There's a bunch of guidelines out there. There's also relative contraindications as well. Consider their functional status prior to the PE. Right? Are they a 40-something-year-old, 50-something-year-old patient who was walkie-talkie, just went on a really long flight, maybe was a little hypercoagulable, now coming in with a high risk of massive PE? Or are they 89, bedbound, chronically ill, completely demented at baseline, right? Like, consider their functional status. Life expectancy should be something to be considered as well. And lastly, clot in transit. If your patient already looks like they're not doing great from the PE, the first hit that they got, and you echo them and you see the large Goomba in the RV that's waving around and looks really scary, those patients are at really high risk for a second hit phenomenon. So consider thrombolytics for those patients as well. I do want to briefly touch on emerging evidence for possible new regimens. There's this new trial that's pretty exciting. It's just an observational study, but it's just exciting nonetheless. It's the Aiken 2024 trial where they used quarter dose 25 milligrams of TPA, quarter dose TPA infused over 6 hours in massive PE. So there's 37 patients, I know, an N of 37, haha, with massive PE. All were on pressors, and they gave quarter dose TPA over 6 hours. And the protocol also called for the quarter dose TPA was allowed to be repeated for an additional 6 hours after one time if the provider thought it was necessary. None of the 37 patients needed this. And of course, heparin was infused, and notably after the lytics, unlike the PATHO trial. And in terms of the outcomes, they looked for improvement of hemodynamic status, echo criteria, and they looked for major bleeding complications. All 37 patients became hemodynamically stable. 18 patients did have a repeat CT in 24 hours post-lytics. 16 of them had total lysis, and the remaining 2 had 75% reduction in the burden of PE. There was no major bleeding. 3 patients out of the 37 had minor bleeding after 2 to 3 days on the heparin drip. None of them required any transfusions. The major, like the bad part of it is there was no control groups. But I think for now we can use some of the safety data that has already been out. For example, the bleeding risk from the Moffitt trial, which used half dose TPA, not quarter dose TPA. And this quarter dose TPA regimen wasn't coming from somewhere out of the blue where someone just decided, oh, why don't we just try a quarter dose? It actually comes from the IR guided therapies where they usually do up to 25 milligrams of TPA infused either over 6 hours or 1 milligram per hour over 24 hours. So up to a dose of 25 milligrams. And those trials also have their in terms of like control groups and those things. So it's, again, a new study, but something just to consider. The Mayo Clinic group is also actively trialing a 1 milligram per hour TPA infusion over 24 hours via peripheral IV. I could not find access to this study, so I'm not going to really mention it any further. So in terms of when we review the evidence and kind of try to come up with a regimen for high risk submassive PEs, if you have one of these PEs with a calculated low risk for bleeding, I think it's fair to use the half dose TPA infused over 2 hours based off of the Moffitt and Wang protocol. High risk submassive PE with a moderate risk for bleeding, patients with a relative contraindication to TPA, is maybe this might be the role for your quarter dose TPA over 6 hours. And the reasoning behind this is you can always give more TPA, but you can never take away. And in terms of the high risk submassive PE with high risk for bleeding, they have a clear contraindication. I think right now it's a little bit too early to say that the quarter dose TPA or even like a peripherally infused 1 milligram of TPA over 24 hours, I think it's a little too early to say that. And at this point, I would say, hopefully, definitely have a risk benefit analysis with the patient and their family and pray that IR can get there on time. So in speaking about IR, I do want to briefly mention IR guided therapies. They have two major types of therapies, catheter-directed thrombolysis versus catheter-directed thrombectomy. I do want to note that in our hospital, we only have catheter-directed thrombectomy using the Inari catheter, Inari flow treatment. Do note about these IR-guided trials. No prospective study has demonstrated a mortality benefit with any of the IR-guided therapies in any of the population of PE patients. Most studies were done by actually the manufacturers of the catheters without any control groups. Most studies. There are a couple of them with the control groups. So why do we decide to go towards the IR-guided therapies? I think there's a couple of reasons. One, it's a little bit tough in the emergency department when we're overloaded with all of these patients and we have a lot of fear in giving the TPA, right? We're afraid of causing harm to these patients that we don't want to do harm to. So I think sometimes it is a little bit easier to ask a specialty service to do some of these things for us. But secondly, maybe the thought of it is it sounds reasonable, right? There's a clot, get rid of the clot, and can you potentially direct your catheter right next to the clot and give a little bit of a low dose TPA and try to bust the clot open, right? So the question, that third point, does clot targeting help? Well, it sounds elegant, but they have done like these animal trials where they've analyzed sort of the hemodynamics around the clot and things. So they put the catheter close to the clot, but they noticed that there was a lot of turbulent flow around the pulmonary artery proximal to the clot. So the conclusion was maybe that the TPA is not necessarily reaching the clot during the first pass. The half-life of TPA is 4 minutes, and you circulate your entire blood volume in a normal heart entirely every minute. So TPA is actually being recirculated around your body up to at least 2 to 3 times, I guess, in the setting of PE with a reduced ejection fraction. So maybe it's the second, third, or maybe even fourth pass that makes the clots less. Moreover, these catheter-directed therapies are really, really ineffective when you have these distal non-targetable clots. It's just something to think about and consider. So this is a poll that we sent out to all the attendings. And we gave them a little prompt about our patient, and we asked the attendings what you would do if a patient like this appeared at your door. And this is actually the result of only 25 of the 48 results that we got. We had to pay $100 in order to see the rest of the results, which was I think a little bit more than what we wanted to do. But thank you to all the attendings that did respond to the responded to the poll. And as you can see here, most attendings at least on the poll, wanted to thrombolyse the patient on the vignette. So let's return to the case. On hospital day 0, a CTA was done 9 hours post-TPA, still demonstrating extensive pulmonary emboli within the right pulmonary artery and RV strain with straightening of the interventricular septum. She was weaned off Levophed on hospital day 0, continued on a heparin drip. On hospital day 1, IR guided recommended no acute intervention. She was extubated on hospital day 2, and an official echo was done on hospital day 3, noting normal RV size and function. She was downgraded on hospital day 5 and discharged to SAR. So I do want to show you her echo side by side. Her old one is always going to be on the right, and her new one's going to be on the left. The left one was one that I did on hospital day 2, prior to the official echo done the next day. So as you can see here, the right ventricle compared to on either side, the right ventricle is definitely smaller in size, and you note that the left ventricle is definitely better filled than it was when she first came in. This is the parasternal short. Notice here the straightening of the septum is not seen in the new echo, and again, better filling of the LV. The apical 4. At the time that I did the echo, she still looks like did have RV dilation, but if you notice the free wall movement, right, it's coming inward. You have loss of your McConnell sign, and you have a really good movement of that lateral tricuspid annulus. So if you look at the TAPSE, remember it was 0.9 centimeters or 9 millimeters when she first came in, 2.65 normal by the time I did this echo. So in summary, consider early thrombolysis for high-risk submassive PE. Your clinical judgment is more important than just the numbers. Echo may help aid your clinical judgment if you're on the fence. Afterload reduction is key in PE, i.e. lytics, but don't forget about the hypoxia, the hypercapnia, not worsening afterload. And consider using reduced dose thrombolytics and wait for the new studies that hopefully will come out at some point. Here are my references, and thank you for listening.